Thank you very much. And it's a pleasure to be here. And I'd like to shift your focus a bit again back to the patient with this picture. And when you look at this picture, we'll see there is quite some stereotypes on the picture. So you do have the young intern, the young dietitian, the young nurse. Then you have the gray-haired guy here who seems quite happy because he sees this patient here. And this patient is at risk of malnutrition, but you see the patient is actually also very happy, and she's looking at the menu of the hospital, and she's ordering steak and eggs for breakfast, and she's ordering fish and pasta with olive oil, and all our problems are solved. Now, you all know it's not the way it works in the hospital, but what I think is important in this picture, you see it is a team approach. Malnutrition management, it's about a team approach. And what is in the middle is the patient. So it's about the patient, it's about engaging patients in the management. So what we need is really to focus on the patient, to focus on the assessment at the bedside, to understand the pathophysiology and to determine the goals of treatment, of care for these patients. And of course, what is very important for us all, we need evidence that guide our clinical decisions in these patients. So we need to know, and we have heard just in the two presentations that there is increasing evidence how to use our energy and protein targets. So I think it's very important that we learn from studies, from trial, that we translate this evidence to our patients. So you mentioned the EFFORT trial, and I think this is a trial that has learned us quite something because it was a trial that had a very basic research question. So if we have two strategies, so we leave the patient just choose his own menu, we don't have any dietitian support, no nutritional support, or whether we use the best nutritional support we can have in the hospital, what does it make a difference? So if we increase protein and energy intake with a team of dietitians, of nurses, of physicians, can we make a clinical difference? And I think those are important trials that help us to guide our treatment for the patients. And what you see here are the results in regard to energy and protein intake. And of course, if you do use a nutritional strategy, if you have this team in place and you talk to the patient and you have your kitchen helping you and you use your ONS, if you cannot reach the goals with your kitchen strategy alone, then you will have an increase in energy and protein intake. And what was important in the study, that this increase was maybe not even that large for every patient. But even a relatively small increase showed a relatively strong clinical effect in these patients. And I think the most important number to demonstrate a clinical effect is still the number needed to treat. So the number needed to treat, as you know, means how many patients do you need to screen and to treat to prevent one severe complication or one death? And you see this number of 25 means that for every 25 patients coming in our hospital that we screen, that we treat, we can reduce or we can prevent a severe complication, and of a number needed to treat of about 40, we can reduce one death. And I think this number just shows us how important the work is of our teams doing clinical nutrition with our patients. Now, in the EFFORT study, not only we found improvements in complications in mortality, but also we looked at other endpoints. We found improvements in functionality. Patients had better quality of life 30 days after randomization. And I think a point that was very important is regarding side effects of treatment. There was no risk of side effects. So if you use nutrition in a physiological way, there is very little risk for your patients. And I think this is also an important message that we try to give to our patients. Now, EFFORT was one large outcome study that showed positive effects on mortality, but it's not the only one. And here I show you an updated meta-analysis of all the studies that we have today looking at the medical inpatient population. And you see the older studies, those were mostly smaller studies. They were a bit heterogeneous in effects. But since 2015, there were about 4 or 5 larger trials. And all of these trials had positive mortality effects. And when you take all these effects now together, you come to an odds ratio of 0.73, meaning that we have a 25% reduction in the risk of mortality if we use clinical nutrition in the medical inpatients at risk of malnutrition. So very strong effects for our patients. Now that we all know these effects, that is well, and that is important. But what is more important is that this knowledge goes now back to the patient. And this is why we also have been very engaged with the ESPEN guidelines, trying to summarize all these different effects we have seen in the trials into pragmatic guidelines. And we have just had 2 sessions on the polymorbid patients with also practical guidelines, giving you diagrams how you can actually apply this evidence to your patients. Now, within effort, I think one important point was that we included polymorbid patients. So, as you have seen, there is many different guidelines, and sometimes you wonder, well, you have guidelines on the geriatric, then you have guidelines on the renal patient and on the pancreatic patients, but the patients we see are often polymorbid. So they're old, they have cancer, they have renal failure, so how do we deal with that? And so I think it's important also to have a holistic approach and look at the overall picture of the patients. And because we had quite heterogeneous groups of patients, we were also able to look at several groups of the patients within the trial. So I want to give you 2 examples. So one example is patients with chronic heart failure. Now, why is this important? Well, if you talk to cardiologists, often they also talk about nutrition with their patients, but their focus is not on protein and energy, their focus is on salt, right? And when we published this paper in the Journal of the American College of Cardiology, there was a nice editorial by the editor-in-chief, and he basically discussed that during his 25 years of practice, he talked a lot about with his patients about nutrition, but not one time he talked about increasing nutrition. He always talked with them about decreasing nutrition, decreasing salt. And I think that's a change of mind also for the cardiologists to understand that they should not be worried as much about the salt, but more about the muscle and the outcome of their patients. And when you look here at the results in the cardiology patients, you see that the mortality effect is quite substantial for these patients receiving nutritional care if they're older, at risk of malnutrition, and have cardiac failure. A second group I want to show you are the cancer patients. And I think we had some great talks also here during the conference, talking also about the concept of starving cancer. Now, we don't want the cancer cell to grow, I think we all agree. But we also have to make sure that the patient is not starving while we try to starve the cancer. So within the EFFORT study, we had quite a large population of cancer patients. And I think we had 2 very important messages here. So the first one is prognosis. If patients have malnutrition, if cancer patients have malnutrition, independent of type of cancer, independent of treatment, it's going to worsen their prognosis. The second question then in the study was also, well, if we use nutrition in the cancer patients, overall, can we have a positive effects on these patients? And we again found that for the cancer population, nutrition was very effective in lowering mortality. Now, I've talked now about the in-hospital treatment of patients, but what happens once the patient leaves the hospital? And I think this is a crucial moment in time, because for us physicians working in the hospital, we tell our patients goodbye, we give them maybe a report, we send them a bill, but often we don't know what's going on with the nutritional care. And I think it's very important also to ask the question, well, what happens after the patient leaves the hospital? And there is also evidence showing us that if we look at nutritional care in an ambulatory post-discharge setting, that we can have a very strong effect on mortality. So you see here, it's about a 40% reduction in mortality for patients receiving outpatient care after the hospital admission. Also, we found in this meta-analysis that it's not only about the duration of treatment, but it's also about the amount of protein you give your patients. So the study found, so this meta-analysis found that there were two main predictors for improved survival in these patients: high protein strategy and duration beyond the hospital stay. Those are two very important points for long-term outcomes of patients. So I think we can conclude that nutritional therapy is effective. We have trials, we have meta-analysis, and it is an effective treatment to reduce the risk of adverse event in the hospital, but also after discharge. Now let's look a bit more specific on the effects of oral nutritional supplements. Within the EFFORT study, we tested a strategy. So if we reach protein goals or energy goals with any means, right, what's the effect? And in about 90% of these patients, using oral nutritional supplements was part of the strategy. But it was not a study that compared yes or no oral nutritional supplements. But there are several studies that have specifically looked at the effect of supplements. So one of them, and this is a meta-analysis of different studies, has compared the risk of complications in patients with ONS versus patients without ONS in community settings. And you can appreciate here, there is quite some research that has been done. And you see there is an overall picture here. And again, when you look at the overall effect, you have about a 30% reduction in the risk of severe complications when you look at this meta-analysis. So most randomized studies found fewer complications in the ONS group compared to the control group. And the meta-analysis overall, which had about 40 trials included, showed that there was a significant reduction in complications risk. Now, when we use ONS, of course, one thing that is also important is compliance. And we know it is not so easy to keep patients' compliance with the ONS. And this is also important for us to understand that compliance is a key factor whether these oral nutritional supplements will work or will not work. And I think this was a good study showing that there is a dose benefit relationship about ONS. So the higher the compliance, the more you can give to your patient, the more you can reduce risks of complications in your patients. And again, you can see it here. The higher you can dose your ONS, the more effect you have in your patients in this study. So my second conclusion is there is evidence from numerous randomized trials and also meta-analysis supporting that ONS are effective in reducing complications. However, we need to have good compliance adherence of patients for them to really work. And I think for the outpatient setting, there is still room for research to really understand whether long-term use of oral nutritional supplement and nutrition can improve outcomes of our patients. And this is why we are currently doing the EFFORT-2 study. So the EFFORT-2 study is the continuation of our initial study, not so much looking now at the in-hospital stay, but asking the question, well, what happened when patients leave the hospital? And if I could have changed something in the initial design of the EFFORT study, we would have not so much only focused on the initial hospital stay, but we would have looked at a longer-term outcome. Because after patients in the EFFORT study left the hospital, we did not follow them up and give them further nutritional support when they left the hospital. And you see what happened in the studies. Those are the 30-day outcomes, and you see these two curves here that I've shown you before. And it seems that the interventional group, the red one here, is kind of bending. And so after 30 days, when we then did another analysis after 6 months, we found that actually these two curves are still somewhat parallel. So we still have about a 10% improvement here. But it seems also we have lost some of the benefit of the initial intervention. And I think a second conclusion of this long-term outcome was that there was quite strong adverse outcomes in these patients. So the mortality rate was about 25%. So a very vulnerable patient population. And of course, you can ask the question, well, we had the patients in the hospital for about 10 days. So you had 10 days of nutritional care. We gave them some advice when they left the hospital. But what would have happened if we would have kept on the intervention for a longer time? Would we be able to bend the curve here, what we all would like to see for our patients? And this is exactly the idea, what we're doing now in the study. We're providing home care at home. We have a team of dietitians that follow up with these patients. We have products for these patients, and so we make sure that they reach their calorie and protein targets at home. Now, it would have been very nice to show you here the real Kaplan-Meier curves, but unfortunately, we have not yet stopped the trial. We're still recruiting patients. But I have been, of course, we do some monitoring of the compliance, and what I can show you here is the compliance in regard to energy intake. And you see those are the two groups, the controlled intervention group at baseline at 3, 6, and 12 months. And you can see that at least we are able to increase energy intake in these patients. And we see a similar picture also for the protein intake, that we, with the use of a nutritional strategy, also including ONS, we are able to increase their intake. Now, whether this translates into clinical improvements, this will, of course, be the main question of the trial, and for this, we'll need to finish up the trial. So I think it's important also to say thank you to all these people that are working for these trials. And you see, this is our team here from Switzerland. I see over there is my colleagues Carla and Pascal, who are working very hard every day to include patients in all these different centers. But now we also have European support from Spain. And I think I've seen Maria here. And thank you also for the whole Spanish group, also Diana, who is helping you a lot. And I think now we are the Swiss-Spanish team who are working and putting a lot of efforts for these patients. And so we are very hopeful to complete our 1,000-patient trial, and then we'll hopefully have a good answer showing us what are the long-term benefits of nutritional care when patients leave the hospital. So with that, I'd like to close here, and I hope in end of 2025 we'll have more results, and of course, I'd be happy to present again once that is the case. Thank you all so much.